Hello everybody, we are going to explain the pre-prosthetic surgery of the soft tissue. Now we are gonna start explaining the reduction of the soft tissue of the maxillary tuberosity. First of all, we have to anesthetize the area of the maxillary tuberosity. The technique that is used are the infiltration technique, where the soft tissue are needed to be reducted. After finishing the anesthesia procedure and the area has been anesthetized, we start with an elliptical incision, as we can see here in figure A. After we have finished the elliptical incision, we excise the soft tissue, as we can see in B. Then we do lateral and medial thinning of the soft tissue in order to remove more soft tissue and to provide tension-free soft tissue closure, as we can see in D. The indication for mandibular retromolar pad reduction is very rare. There is a false indication for this procedure because the patient, when loses his teeth, he loses his correct occlusion, so the jaw relation will be incorrect because the patient tend to protrude the mandible forward. So the dentist should make sure that there is a contact of the retromolar pad area when the patient in centric occlusion before referring the patient for a surgeon. The technique for anesthesia is infiltration. An elliptical incision is used to excise the greatest area of tissue thickness in the posterior mandibular area. For flap margin preparation, we have to avoid excessive preparation of the lingual aspect because the lingual nerve is nearby and the lingual artery is nearby, so we have to avoid damaging these important structures. So we do preparation more in the labial area than we do in the lingual area. The tissue is approximated with either continuous or interrupted sutures. The etiology of unsupported hypermobile tissue is the resorption of the underlying bone and the ill-fitting denture. The management: if there is a bone resorption and the height of bone is reduced, we have to do a bone augmentation. If adequate alveolar height remains after reduction of the hypermobile tissue, then excision is indicated. The surgical procedure consists of the following. First of all, we have to use a local anesthetic injected adjacent to the area requiring tissue excision. Then we remove the hypermobile tissue in the alveolar ridge by two full thickness incisions that are parallel, one buccal and another one is lingual, of the tissue to be excised. Then a tangential excision of small amount of tissue in the adjacent area may be necessary to allow for adequate soft tissue adaptation during closure, as we can see in figure A and figure B. For the lower jaw, as we can see in A, there is a hypermobile tissue. Then we use a pickup and scissors are used to excise the cord-like mobile fibrous tissue without perforating the periosteum, as we can see in B. Denture impression can be usually taken 3 to 4 weeks after the surgical procedure. Inflammatory fibrous hyperplasia, or as known upulus fissurata or denture fibrosis. It is a generalized hyperplastic enlargement of mucosa and fibrous tissue in the alveolar ridge and vestibular area, which most often result from ill-fitting denture. If it's in the early stages when fibrosis is minimal, non-surgical treatment with denture in combination with a soft liner is frequently sufficient, as we can see in the picture 1. Delayed stage, when significant fibrosis exists within the hyperplastic tissue, excision of the tissue is the treatment of choice, as we can see in the picture 2. The surgical procedure consists of the following steps. First of all, we have to local anesthetize the area using infiltration technique. Then the redundant area of the tissue are grasped with tissue pickups. A sharp incision is made at the base of the excessive fibrous tissue down to the periosteum. The hyperplastic tissue is removed. The adjacent tissue is gently undermined and reapproximated using interrupted or continuous suture, as we can see in A and B. In C, we have a large area of fibrous tissue and the wound margin should be sutured to the periosteum. The labial frenal attachment consists of thin bands of fibrous tissue covered with the mucosa extending from the lip and cheek to the alveolar mucosa. A is the labial frenum. The surgical procedure consists of the following. First, local anesthesia. Infiltration is often sufficient or for surgical treatment of a frenal attachment. There are two types of excision. The first one, the simple excision technique. A narrow elliptical incision around the frenal area down to the periosteum is completed. The fibrous frenum is then sharply dissected from the underlying periosteum, and soft tissue and the margin of the wound are gently undermined and reapproximated. After finishing the undermining procedure, a placement of the first suture should be at the maximal depth of the vestibule and should include both edges of the mucosa and the underlying periosteum at the height of the vestibule beneath the anterior nasal spine, as we can see in F and E. This technique reduces the hematoma formation and allows for adaptation of the tissue to the maximal height of the vestibule. The remainder of the incision should then be closed with interrupted suture. Occasionally, it's not possible to approximate the portion of the excision closest to the alveolar ridge crest. This will undergo secondary epithelialization without difficulty, as we can see in H and G. In the Z-plasty technique, we do an elliptical incision followed by two oblique incisions are made in a Z fashion, one at each end of the previous area of excision. The two pointed flaps are then gently undermined and rotated to close the initial vertical incision horizontally. This technique may decrease the amount of vestibular ablation sometimes seen after the linear excision of the frenum. The lingual frenectomy consists of the following steps. Bilateral lingual blocks and local infiltration in the anterior area provide adequate anesthesia for the lingual frenectomy. The tip of the tongue is best controlled with a traction suture. Replacement of the hemostat across the frenal attachment at the base of the tongue for approximately 3 minutes provide a vasoconstriction and nearly bloodless field during the surgical procedure. After removal of the hemostat, an incision is created through the area previously closed within the hemostat. The primary goal of ridge extension is to provide an enlarged area and to improve the extension in the area of denture flanges by removing the dislodging effect of muscle attachment in denture bearing or vestibular area. The first procedure is the lip switch. First, we do incision in the labial mucosa, and thin mucosal flap is dissected from the underlying tissue. Supraperiosteal dissection is also performed on the anterior aspect of the mandible, as we can see in A. B. The flap of the labial mucosa is sutured to the depth of the periosteum, to the depth of the vestibule. Exposed labial tissue heals by secondary intention. Then, we do modification of the technique by incising the periosteum at the crest of the alveolar ridge and suturing a free periosteal edge to the nuded area of the labial mucosa, as we can see in C. D. The mucosal flap is then denuded bone to the periosteal junction at the depth of the vestibule, and in A, preoperative photographs and F show the result of the surgery after 6 months. The vestibule and the floor of the mouth extension procedure. First of all, as we can see in A, preoperative muscle and soft tissue attachment near the crest of the remaining mandible. Then we do a crystal incision is made, buccal and lingual flaps are created by supraperiosteal dissection. After that, sutures are passed under the inferior border of the mandible, tethering the labial and lingual flaps near the inferior border of the mandible, as we can see in C. Then graft held over the supraperiosteal dissection with a stent stabilized with circummandibular wires, as we can see in D. E shows a post-operative view of the newly created vestibular depth and floor of the mouth. Soft tissue surgery for maxillary ridge extension, submucosal vestioplasty. First of all, we use a mouth mirror placed in the maxillary vestibule under the upper lip and elevated again the anterior wall of the maxilla to the desired post-operative vestibular depth. If no abnormal lip shortening occurs, then adequate mucosa exists to perform submucosal vestioplasty. Then an anterior vertical incision is used to create submucosal tunnel and then supraperiosteal tunnel along the lateral aspect of the maxilla. C demonstrate cross-sectional view showing the submucosal tissue layer. D excision of the mucosal soft tissue layer. Then we do splinting to hold the mucosa, again the periosteum at the depth of the vestibule until healing occurs, as we can see in A.